great. I see we have 33 participants on the call already. I think it's fair time for us to begin the session. Probably a lot to talk about. Okay, if everyone's happy. So good evening, everyone, and welcome to this session well awaited on the National Health Insurance and its associated bill. And as we know, this bill has been spoken about with its intentions to overhaul the healthcare system in the country and the concept of universal health coverage, which is indeed praiseworthy. And tonight, we're going to be looking at the historical perspectives as to why the National Health Insurance Fund is being implemented, the implications it might have for all stakeholders, including consumers, providers, both the public and private sector, and then the overall economic impact of the national health insurance. I'll be your host this evening. I'm Dr. Navisha Parag at Regent Business School, and it gives me great pleasure to welcome both our esteemed guests from the Board of Healthcare Funders. We have Dr. Rajesh Patel, who is a family medicine physician and also the head of health system strengthening at the Board of Healthcare Funders. He's quite a public figure and always in the news. So here he is with us this evening. And then we also have Mr. Charlton Murove, who is a health actuary amongst many other accolades, and as well the head of the special research unit at the Board of Healthcare Funders. And you can read more about their profiles on the invitation. So, well-awaited session. The reason why we're having this session this evening is because the NHI has once again come into the limelight with just a few days to go for public comment on the bill. It is indeed time we consolidate our thoughts and our feelings and emotions around it. And in that sense, we've invited our expert colleagues this evening to speak to us about it. The bill itself, why it's so contentious, it's often being read as being too vague, perhaps unconstitutional, and in a lot of ways invalid. Whether or not this is true, let us find out more about our colleagues' opinions this evening. So without further ado, I'd like to welcome Dr. Raj Patel and Mr. Charlton Murove. And just before we hand over to you, just some housekeeping rules. Please use the chat for any questions you have for our panelists, guests this evening. And as well, before you log off this evening, please just drop your MP number or your HPCSA registration number in the chat or Q&A session so that we may log your CPD points. Okay, welcome, Rajesh and Charlton, and thank you so much for being here this evening.
Thank you very much. Thanks for inviting us again to the sessions with the students.
Thank you, Rajesh. Thank you, Charlton. So I think to kick off the session, perhaps it is important to just look at why we are here, where we're at with the NHI today, and the historical perspective surrounding it. I think, Rajesh, if you want to kick off with that.
So NHI has always been a ANC policy for many years. And you might recall in the early 1990s, there was a initial document that was prepared by Dr. Olive Shisana and Johnny Broomberg. So that was one of the first documents that was published and moots the whole NHI at that stage. However, during the process after that, the individuals in the Department of Health, it was probably more critical and important. And it may have been because of the financial constraints at that point in time, that it might be actually appropriate for those that are currently employed to belong to medical schemes and to work towards a transition towards a social health insurance at that stage. And obviously, that's the direction they were going. That's the kind of trajectory that they had until we had the situation in 2007. There was a lot of hype about problems in the private sector. And if I'm not mistaken, I think those that were involved in the unions literally drove the agenda of NHI again and resurrected it, took it to Polokwane. And obviously at the Polokwane, besides some of the important things that took place, the decision was made to adopt and embrace universal healthcare, not universal, NHI. Critical in that regard kind of thing, there was a lot of legislations pending, particularly for medical schemes that were sort of stewarding the industry towards a lot of reform. And unfortunately, a lot of that was put onto the back burner. And from that time till now, no sort of, oh, there goes my lights. There's been no reform at all in the private sector per se, in the medical scheme sector, but if not only in the medical scheme sector, even the other regulatory bodies, etc., that have a bearing on the private sector, has never been really reformed, never been attended to, etc. So we've right now, as we look at it, 2 years, 20 years almost, of no leadership, no stewardship, no direction. And there's been this uniform or single-minded focus driving the NHI agenda as if that would solve all our problems. And that's unfortunate kind of thing, that instead of trying to fix some of the things that aren't working, keep the things that are working and trying to maintain them, there was this whole idea that NHI is the most important thing and all efforts were driven towards that. And it's just unfortunate that that has happened. Obviously, I think it was 2011 or something when the green paper of NHI was produced, and then there was the white paper subsequent to that. It was clear at that point in time, from the Ministerial Advisory Committee to the production of the green paper, that there was a multi-stakeholder input process, which was fantastic. That NHI was seen as this national asset, and everyone was brought in to participate in the Ministerial Advisory Committee. A green paper was produced. Everyone submitted comments. I know the work that BHF was doing at that time. In the green paper, if you see a chapter on how providers should be paid, that document was literally prepared in the offices of the BHF and submitted. And because they accepted it as is, it was copied and pasted into the green paper. So at that stage, it was clear that this was going to be a collective effort to literally build NHI. Subsequent to that, the white paper was produced. And in fact, if you look at the size of BHF submission to the green paper, it was quite a lot. Come the white paper, you could see there was definite narrowing of the agendas, etc. And our submission also was quite smaller. And it was great kind of thing. Following that white paper, there was consultation processes to try and identify the issues, explanations, etc., so they could fine-tune the NHI bill and produce something. However, after Minister Aaron Motsoaledi left and you had a new minister come in, suddenly an NHI bill got published, which is the one we're familiar with, the A bill. And it's clear from this NHI bill that was published that literally everything that came through from the green paper, white paper, etc., was literally ignored and sort of discarded. Perhaps the only thing you can say that exists from the previous versions going into this one is how providers need to be remunerated. And that too, there's problems in the way it's structured in the bill, and we can touch on that a little bit later. So that's more or less the history. It seems like this was totally new. There were things that were put into this document which sort of come from Thailand, the so-called contracting units of primary care, etc. It's worked there, and they obviously brought it here. And we could talk about why some of us are not entirely happy with those recommendations, even though there might be merits and it worked in those countries, why we think it's a bad idea here. And I think that's sort of the context, if I can put it there. We're very much supportive of NHI, and I think NHI as a financing tool to redistribute the way money is being used in the country is absolutely important. We need to address the inequitable distribution of money between provinces, between private, public, etc., and really allocate money on the basis of health needs. So from that perspective, you can definitely put a tick for NHI. It's definitely an essential tool to have in place. It's one tool, and let's make it clear, it is a tool. It is not this one that's going to save the entire country and fix the entire health system. It is just a financing tool, funding tool that we have, and we need to put a tick to that. I'm sure everyone's familiar with the WHO 6 pillars, and this one just probably ticks the one component out of that. It's not a solution to the health system. Absolutely not. So from that perspective, we all embrace universal healthcare coverage. Unfortunately, we're like 7-8 years already down the line and very little done other than this bill that's been produced. We only have another 7 years to go to 2030. So literally, the target that we had in 15 years, we now only got about 7 years to achieve. And literally, this is why, in some way, it's a little disappointing that while they say NHI is going to take 20, 30 years or whatever to get completed, we're not fixing other elements within the health system. And that's a little bit disappointing. And it's clear in the previous publications that were out there, the Lancet Commission, the Health Market Inquiry, just to name a few, literally strongly criticize government, the minister, for their lack of leadership and stewardship. And I think if you look at the 6 pillars, that's the first one, and probably the most important if you want to strengthen the health system. Maybe I'll stop at this point in time and ask my colleague if he's got any additional comments with regards to background.
Yeah, sure. Thanks, Rajesh. Yeah, I think what I'd like to add on in terms of the history is probably just talk about what NHI is, because when one looks at the current discourse, people often forget what NHI is. NHI, National Health Insurance, is a funding vehicle, and by definition, which is supposed to cover everyone. And when you now listen to a lot of the discussions, they convolute NHI with the whole health system. And if you now look at how the bill has been structured as well, it talks a lot of health service provision as opposed to funding healthcare. So the debate for NHI, I find it quite inappropriate at many levels. First of all, just the understanding of it. NHI is an insurance. There's no one who would argue against people getting insurance when they need care. But the proponents or the government, they've made NHI the whole health system. Hence, the lack of reform that Rajesh was talking about. They don't want to talk about anything in the healthcare system outside NHI. They want to stop everything else in terms of amendments or improvements to the health delivery system, the availability of medicines, improving regulation for medical schemes, because there is NHI. And I think that has kind of led people the wrong way when they look at NHI. And I think one more maybe point which I would like to add, so that at least we anchor our discussions correctly. If you watch what's happening in the media, there's a lot of criticism around NHI, and there's a lot of discomfort around it. And I don't know who to pass the buck to, but there's almost a incorrect perception where people talk about NHI as if let's have it or let's not have it. Whereas what we should be talking about at the moment is, are the things that are proposed in the bill workable? How do we improve them? Like Rajesh was saying, people want universal health care. There's no one who would really stand up and say, we don't want people to be covered under NHI, because it's just a funding vehicle. But now the discussions have taken a wrong turn. We are not talking about the intricate details to check, to go and check if what is being proposed is workable. But now it's almost like, no, we don't want NHI because it's going to take away my medical scheme and so on, which is, in my view, a lost opportunity in terms of how we can actually fix the bill and have a workable funding mechanism for health. So I think in terms of background and also maybe explaining where we are and why things are where they are, I think that would be my introductory remark.
If I can just add on what Charlton says, the purpose of NHI is actually to separate the funding from service provision. And that brings in an element of accountability. If we look at our public sector, the provinces are both funders and they serve providers of service. So really, there's not much of checks and balances. And I probably use a crude analogy to say, imagine having the prisoners in a prison kind of thing being the warders at the same time. You know, that kind of system really not necessarily is going to work well. And that's why always if you want good governance, you want accountability, you need to have checks and balances. So the introduction of an NHI is very good in the sense that you get paid if you deliver care. If you don't deliver care, obviously there's no flow of funds coming through. And it then creates a system where those in the service provision environment start jacking up the quality of care, start making sure all the ducks in the row that they need to have to provide adequate service are there and are in place.
Perfect. Thank you so much. And I think for our listeners on the call, the take-home key message here as a starting point is that the NHI does not equate to universal health coverage. As both our speakers said, it is a tool, it is a funding mechanism, but it does not in itself equate to universal health coverage. And I think a lot of South African citizens are under false belief that this fund would ensure that they can access healthcare at any time, anywhere, and for whatever their healthcare needs might be. Now, one of the objectives of the NHI being to have one public health fund which is created with adequate resources to meet the health needs of the entire population. I think that's the key starting point of this entire conversation. What is adequate resources and do we have them? Now, does it be this infrastructure, finances, and human resources? I think we can touch on each of those in turn. Rajesh and Charlton, over to you.
Charlton, to some extent, this is financing. Why don't I throw this monkey on your shoulder?
Okay, yeah. Whew. So the objective which you have outlined, the single fund, I think it's one of the biggest bonds of contention with a lot of stakeholders, especially in the South African context, where you have so much governance failures leading to corruption. So people are scared. If there's anything, you don't mess around with people's healthcare. When they need healthcare, it must be provided. So I understand the anxieties of the citizens in terms of that trust deficit. And then setting up a fund like that, it is going to be incredibly expensive. We are talking about Eskom and load shedding. NHI will be so much bigger. And then I think a lot of people maybe in the room, they do work in healthcare. I think one thing that we must acknowledge with healthcare is it's an incredibly complex system. There are so many players in the system, so many vested interests within the system. If I can just list, you have health service providers, a lot of them. And one unique thing about healthcare is if I am a patient, I don't know what I need. I have to go to my GP who is going to tell me what I need and is going to direct my care. And his interests, well, might be to look after me, but he also needs to make a living. I think in one of the last discussions, the minister was talking about Mesaratis for specialists being taken away and then having Mercedes-Benz. So when you set up a single fund, it has to be foolproof to all these vested interests, and it has to have a huge admin function to try and deal with all these things. So a lot of people say they just don't believe that we've got the capacity to manage a single fund and effectively deliver care. So that's just a comment around the single fund. And then in terms of the amount of funding required to have an NHI, I think my considered view is the amount of money that would be needed is going to actually depend on the benefits that have been specified in how care is delivered. What is proposed in the bill, though not clear, there's almost an insinuation that the role of medical schemes is eventually going to decline. So then that would almost imply that you are going to have a very rich benefit offering from the fund. And then that means obviously you need lots of money. So that is why you see so much people saying maybe VAT will need to be increased by up to 22%, or personal income taxes will need to be increased by 10, 15%, so that we can fully fund NHI. So the issue of the cost, obviously it's going to be quite expensive. We have a very thin tax base in South Africa. That takes away the latitude in terms of increasing tax. And then we also have a huge debt burden. So we are sitting at a point where already there isn't much fiscal space to increase taxes. Now, if you listen to the proponents of the current bill in its form, they have this, I'll quote, magical belief that Charlton and Rajesh are paying for their own medical aid scheme. So collectively, we have 250 billion being paid towards medical schemes. So when we have NHI, we are going to take that 250 billion and add what is currently spent by the health budget, and boom, we have our 500 billion. The reason why I say magical is I pay because I want to pay. The moment you have an NHI, I'm going to say to you, but wait, I'm already paying personal income tax. So why should I transfer the current money that I'm spending on my medical aid and give it to you in trust that you do it? So there's no practical link of how they will actually try and get the funding that they're targeting in the private sector. It's just not going to happen. So that creates that funding gap as well as the anxiety. And then there's also some hidden costs which they are not speaking to. Medical aid schemes were traditionally set up by employers. I think over time they've evolved and become independent commercial entities who exist on their own right. But there's a reason why employers set up these funds. It's similar to Social Security. Employers set up retirement funds, right? They want to look after their employees and have a workforce that is healthy and productive. So bringing in NHI, as it is proposed, you'll find that it's going to cause a lot of anxiety in terms of employment. If they increase taxes, maybe amount of employment is going to go down, and then you also have a reduction in the tax base. And then directly for employers, they might still decide to fund for the healthcare of their employees separately. So it's not impossible that you end up finding that this private healthcare that we currently enjoy is going to be outsourced to other international insurers, and then we end up losing money as a country. If you go to other poor developing countries, you find a lot of NGOs, when they have employees, they make them join the international insurers, and when they need care, they airlift them out of the country and so on. So the funding, yes, many questions. No one knows about that. And in terms of the implications on the economic front, I think not much attention has been given to how it's actually going to impact on people. And obviously, I don't foresee them being able to increase taxes that much. I think you've seen recent utterances from the Minister of Finance, literally saying to them, I wish we would spend this money rehabilitating hospitals rather than set up an NHI. Even to him, it's unclear how it's going to work. So yeah, I think Rajesh can add onto that.
Yep. Certainly. Thanks a lot, Charlton. I think Charlton made a comment about the contribution to medical aid, and maybe there's an opportunity to raise the first constitutional issue. The contributions we make to medical schemes, the first component, which is the tax credit. Yes, government can potentially take that away, and that's about 30-40 billion that can be injected into NHI. But the rest of the contributions to medical scheme is out of our own pocket. And that is effectively our discretionary expenditure that we're using. And this is where the first constitutional issue comes in, is by putting in the clause that medical schemes will only offer complementary cover, they are effectively taking away your rights of dignity, self-determination, and whatever you do with your after-tax money. They're effectively telling you that you can't spend your money the way you want to spend it. And that becomes the first example of a constitutional issue. And if you see our submission, and I'm sure that will be shared with the students and the classes out there, actually talk about that component, is that you cannot impose legislation on people which then determines kind of thing how they can spend their money. Absolutely not. There's many other constitutional issues, and we can tackle them as we go through the discussions a little bit later, but this is one of the first important ones that comes through. And it's been raised a couple of times, not just by us. The parliamentary legal advisor had informed the Parliamentary Portfolio Committee on Health that this is a constitutional issue. And despite that advice of the parliamentary legal advisor, they still went ahead and kept this in place. So it shows that the politicians are even sort of disregarding the legal advice from their own legal advisors in this regard.
Certainly. And thank you so much. I think whilst we are funding, and a few, I don't know if these are misconceptions or these are realities that we faced with. So let's say the NHI is fully implemented and medical aid schemes as a country stand may only offer complementary services or benefits to cover those that are not otherwise covered by the NHI bill. Does this then mean that those 9 to 10 million people that are currently paying towards medical aid schemes are then the responsibility of the NHI fund as well, which sounds a little bit regressive in terms of the spending on healthcare in the country?
That is to some extent true, because what they are saying when NHI is fully implemented, and we can talk about this clause 33 that's in the NHI bill, as well as the medical scheme amendment and the legal connotations around that component. What they're actually saying is that NHI will then fund a whole component of basket of care, and literally you will then cover anything that NHI doesn't cover. And it's obviously assuming that it will be they use the word comprehensive. Now, I'm not sure where comprehensive starts and where comprehensive finishes. To me, that's an infinity type of thing. And it's a policy statement, and you definitely can't translate that into legal language, but they still use that word. So the extent to which that complementary cover comes in is only dependent on the details of what benefits are in place and the level of affordability that comes in. However, this is where, when it comes to the benefits also, there's a whole lot of complexity that comes in. An example is the Ministerial Advisory Committee will determine, not will advise the board, will determine what benefits are to be offered. What that means, the board really has no say in it, even though they'll consult the board, etc. And between the board and the minister, or consulting with the minister, will then finalize their benefits. And your other problem comes in that here's an external body that will determine what benefits you have to offer. There's another external body called Treasury, who's going to tell you how much money you're going to get. So you as a board sitting in the middle, you can't even work out this benefit, what it's going to cost, and to collect that money. You're just going to be given money to, and you have to fund whatever someone else decides you have to be funded. So the question comes in, how long is that money going to last? Currently, if you look at public sector, etc., it lasts a whole lot of months, and then last couple of months, they're in deficit, they borrow money, etc. And this model that you have is identical in another structure called a road accident fund, which at this point in time is actually insolvent. The benefits are determined in legislation, the money is determined through the levy and passed on from Treasury across to that. So the board in reality is actually not accountable from a fiduciary perspective. And that's part of the legal problems that the current bill has, in that it's not structured well from a governance perspective, not structured well even from a legal language perspective. There's a lot of vague terminologies that are in there, which is another component of the constitutional problem, in that the law requires it to be in absolute clear terms. And what you have is a lot of gray terms in this document, and it's very badly drafted. I'm not sure if I answered you fully, but I have gone a little bit on the side as well. I'm not sure if there's anything else I can elaborate on.
You certainly have. And I think, Rajesh, touching on that point that you just made in terms of the way the bill is phrased and the language used in the bill, one of our participants, Dalma, posted in the Q&A that there's an actual gap in the knowledge base, even for healthcare administrators, with regard to the public funding of healthcare and how it actually translates into the delivery of equitable care. And I think partly to blame is the way in which the NHI bill is being spoken about and described and depicted in writing. It's very unclear and uncertain, which has created a lot of doubt that we all have. But no doubt, I think everybody other than the proponents of this fund itself agrees that the NHI is fiscally risky. and the cost of the NHI, which I believe they costed it based on 2010 figures to implement in 2026, in itself doesn't make sense. The 256 billion rand or outlay cost that is required, does that even equate to enough to cover all of the outstanding medical legal claims that are out there?
And that too, it doesn't take into account the benefits that are on offer and the new technology improvements over time. You know,
Absolutely.
so talking of the fiscal problem, if you structure organizations in this way where the board does not have accountability and control, okay, and you've got the minister that's involved in the decision making, the question is, if something goes wrong, who's actually accountable and who's doing the checks and balances in the scenario? But the financial problem is not just in the NHI, it's not new. If we look at the way provinces are run, and the money is that they're allocated, inevitably the last 2 or 3 months, the budget is already finished and they literally go into overdraft, borrow money to service the public kind of thing for the last few months. And then when the new money get allocated, that first lot of money gets to pay off the previous year's debts. And then you're literally in a vicious cycle of not having sufficient funds. And to some extent, the problem stems in it is a constitutional mandate that says you need to provide care. But there's no sort of control on the financial side. You obviously, all the provinces are dependent on money allocated from Treasury. The way the laws are structured in the country is that every province, if they have a deficit, they can themselves raise taxes. So Gauteng as a province, if it's short of money, it can raise its taxes. Same as KwaZulu-Natal, Limpopo, etc. But obviously politically, that's not palatable. If any government sort of implements an additional tax, the likelihood of that government being in power for the next elections is probably almost zero type of thing.
Yeah.
So obviously that's one of the reasons why provinces have been very reluctant to actually implement this. And this system actually exists in the US. Each state has its own tax besides the federal tax people pay, etc. And I think this has been the big problem, is that the Constitution is obviously providing a certain mandate, but there isn't money flowing into the system to be able to deliver on that mandate. And therefore, something needs to give. You know, something needs to change and to try to make it financially possible. Either you reduce your benefits on offer, or you have to start raising money somewhere along the lines if you have to.
Yeah.
Let me give Charlton to actually comment on this component as well.
I actually want to answer the comments which are open in the Q&A. Right. So I think we are discussing things at a high level. And with your permission, I just want to go a little bit more technical so that at least you can understand why there's a lot of discomfort. Time allowing, I want to touch on 2 things. The first one, I want to talk about how the bill is structured when it comes to contracting health service providers, right? We have a very unfortunate situation where the bill is prescribing how providers will be reimbursed. They say it will be strategic purchasing, right? So that's so awkward. We promote strategic purchasing. It's a good thing to do and so on, but you don't put it in legislation. It means that if you see a service provider and the service provider wants to be paid on a fee for service, or maybe the service you're getting is appropriate in a fee for service environment, the fund won't be able to pay for that, right? So they should not put in legislation how you contract a service provider. It's too much detail. Even if you look at medical schemes, you don't have that in prescribed. You just say you will pay for the relevant service in the most appropriate way. That is what they should have done. And then looking at service providers, they say that you, as a service provider, you must be registered with your council, your HPCSA. After you are registered at your facility, you are also supposed to be certified by the Office of Health Standards Compliance. We know that the staff complement of that office is about 200 people. I don't know how many state entities or facilities they will have to go to certify them, but they are still not able to certify all state facilities. in the private sector, we estimate that they will have to go to another 70,000 to go and certify them. Then once you are certified by the Office of the Health Standards Compliance, you will be accredited by the fund, right? I don't know what accreditation by the fund means, but I think there will be some active process where they will accredit you as an appropriate service provider, and they've put it in legislation. Once you are accredited by the fund, before you render a service, you must be contracted, right? And I want you to think about this. A contract is a one-to-one relationship, right? So the fund, after accrediting all the service providers, they have to have negotiations and contracts with all these institutions. So it's 4 stages that need to be qualified, and contracts have a start date and an end date, right? So already what I've just said means if you want to go and see your GP next door under an NHI dispensation, you must have all these tick boxes. Otherwise, the fund cannot pay that GP. And you must also, I mean, maybe the contract will cover the strategic purchasing component. And then there will be coordinated care. So if you stay close to a hospital, which I will not name, which you don't want to visit, then that's the hospital you're supposed to seek care from. If you're next to a GP whom you don't like, that's the GP you're supposed to seek care from. So there is this impression that people will be able to get care wherever they want or anywhere. It's not in legislation. You will have to get care and follow the prescribed pathway, which is obviously much more strict than what we currently have. So if public health facilities are not fixed, people who stay close to those facilities, they're still going to go and utilize those facilities. So NHI is not really going to change anything for them because they already have access to those facilities. The real issue, maybe to quote the minister, is why don't we fix the infrastructure so that everyone has a good and reasonable level of care at properly managed facilities. So I think I'm just trying to paint a picture of the detail, which is being probably not talked about because people are glossing over the big issues and not looking at why they actually need to make sure that the bill is fit for purpose. The other thing maybe I want to talk about is the complexity which is going to be brought about by complementary cover. I think it will be very difficult to define what complementary cover is. They say that the fund will only pay for your service if you follow the referral pathway. Say I want to be funded by my medical scheme. Does it mean that if I deliberately move out of network and do not follow the referral pathway, I'll still get cover from the scheme because the fund will not pay. So the scheme should pay. And then the definition of the benefit package, it has to be quite strict and very restrictive such that they try and stick people there. So the implementation of the complementary cover, from my own point of view, it will be highly impractical. There will always be people finding ways around it. What if my local GP decides not to contract into the fund, right? Does it mean that he will have access to all the private patients and not be paid by the NHI fund? And then if we also look at other environments where they do have the NHI, a lot of health service providers actually say that they want to have a split of patients where you have 80% funded by the government, 20% may be funded by the private sector. And their whole idea is the private sector will pay me maybe 2 or 3 times more and they pay on time. And I'll get my payments from government after 6 months or so. So at least if I have some private patients, I can keep my facilities running. So I think when you go into the detail, you start seeing a lot of gaps, and you see there are a lot of gaps where maybe the drafters of the legislation didn't think things through, and they didn't debate the ideas that much.
If I can come in on a comment that Charlton made, he obviously described that 4 stages of contracting, but it's a lot more complex than that. Charlton forgot to mention that there's a thing called Public Finance Management Act.
Oh, yeah.
And in Public Finance Management Act, there's a statement that if you want to contract with any state entity, you then have to have yourself listed as a service provider on the Treasury website as a service provider to state, and only then can you do the contracting. So it's a multiple stage process here, and the complexity comes in is that why would I want to go through all this headache and perhaps additional costs, etc., to contract with an NHI if I'm not even certain how much I'm going to get? I will probably only start the journey once I more or less know what the content of that contract is, how much will I get paid, etc. And if I go through the accreditation process, who's going to pay for the inspections, the certifications, and all that will get done by Office of Health Standards Compliance? There's no clarity in this regard. Will Department of Health pick up the cost because Office of Health Standards Compliance is part of the National Health Act? Would the NHI pick up this cost because it's about contracting with NHI? Or is there an expectation that the practice or the facility will hire new staff, and this is both public and private, new staff to do the registrations, to be trained for the system investments component that are required, but literally to be online, etc., with the NHI to be able to do all the type of registrations, etc., of the patients. So there's huge implications at that level kind of thing at accreditation. And I think Charlton started with a good one, is because according to the NHI bill, registration as a user of in the NHI system starts by going to the provider and registering there, which brings in a whole new anomaly. If you join a medical scheme, do you go to a provider to join the medical scheme, or do you join the medical scheme itself? And who provides that service to join that medical scheme? It's the medical scheme and the administrator that provides it. Yet here you have a scenario where the NHI is supposed to separate funding from service provision, and the registration to an NHI is done by a service provider. That in itself raises a whole lot of risk scenarios that come in. And really, you want your costing and your resources that you should have in-house to be doing that work. Now you're subcontracting it out to someone else. And that's part of the technical problems that haven't really been well thought through, is that the registration process should actually be the NHI's responsibility, not service providers.
Thank you very
Navisha, I
much.
know you had some
Rajesh.
questions there.
Thank you so much, Rajesh and Charlton. I think we have some questions in the Q&A which I'll address right now. But just to touch on a point you both seem to make, in that this Office of Health Standards and Compliance being tasked with the accreditation of facilities. Now, currently, I think only around 300 of 3,800 and above public clinics meet that ideal clinic status in order to be to fulfill the requirements for to access the fund. What is the implications for people then needing to access healthcare? I mean, another constitutional aspect now is the access to healthcare, which is a constitutional right. But with not meeting the standards set out by the bill, and not having the capacity in terms of human resources to accredit certain facilities and more facilities, does this now mean people have to travel further? Does it mean they are promised an NHI fund and free healthcare but cannot actually access it? What are the implications for people and the South African citizen?
Navisha, this is the area that really worries me a lot. I think if you really look at the last Office of Health Standard Compliance report, it shows you that a very few facilities in the public sector met those requirements. What that means is that if you want to get broad scale adoption and registration, you're going to have to drop your standards, or you're going to start off very slowly and only with people from those regions where those facilities are accredited. And that introduces a new complexity kind of thing in that for the province and the service provider, let's take province as an example. I might have 2 facilities that are accredited. That means now for the 2 facilities where people register, I'm going to get some money from NHI after delivering that service for those set of people that are registered. And that means the Treasury has to have a twofold type of mechanism of distributing for those by the basis of being registered, and then provincial budget allocation for the rest of the population that aren't registered. It introduces massive complexity kind of thing in terms of that budget allocation to province as well as payment via NHI. And I don't think people have really thought this thing through as to what will happen. And besides making it complicated in that regard, there's a whole lot of foreign people in South Africa that the Constitution mandates you to deliver. About 2-3 weeks ago, I was in one of the forums, and one of the young doctors who's doing community service said, you know what, I'm working in a community hospital. We have a 25-bed maternity ward. 23 beds are occupied by foreigners and only 2 are South Africans. Okay, that gives you a sense of how much resources need to be pumped in to meet our constitutional mandate and how much potentially will be benefiting the people that are registered on NHI. And it introduces a new component in that I talked about the medical scheme amendment on complementary cover. So complementary cover is written in 2 places, in Section 33 of the NHI bill and in the medical scheme amendment bill. And sit and wonder, why do you need to have the same provision of complementary cover written in 2 places? You have it written in one, and that becomes law across the country. You don't have to have it written in 2 places. But the complication comes in the sense that in the Medical Schemes Act, there's an additional component there, and it says that maternity care cover will be taken out completely from medical schemes. Now, there's a history in this country where the president had signed into proclaimed certain provisions of acts, and guess what? They weren't ready to implement. And they had to go with sort of a begging bowl to the Constitution to say, I messed up kind of thing. Please, can we reverse this proclamation that was signed? And we're just concerned that because you got it in 2 places, the president might just accidentally sign off the amendment to the Medical Schemes Act. And if that does happen, the very next day, there will be no more maternity services for anyone who belongs to medical schemes. What that means is that if you want to have your maternity care in private sector, you'll either pay out of pocket or you end up going to the public sector, where you might stand in queues and hopefully you get beds or no beds, or you sleep into double beds kind of thing below and above the bed, etc. in that type of scenario. And obviously, in any one of these circumstances is simply not acceptable. And this is why we're very concerned about the amendments in the Medical Scheme Act. We actually think that's not relevant and should be taken out completely. And in the worst case scenario, if they're still married to complementary cover, rather stick with what you got in the National Health Insurance Bill, Section 33, which is probably better because it says that the minister will pass regulation when it's fully implemented. Whereas in the medical scheme bill, that clause is actually missing. So the moment the president signs it, it becomes immediate effect. And it's not even written that the minister can sign when it's fully implemented. And that brings on an additional component of the constitutional problem, is that there is no guidance in that clause, Section 33, of what fully implemented NHI is. You know, whether it's 80% accredited, whether there's so many service providers around and so many percentage of the population covered. So literally the way it's written, minister will pass regulation when fully implemented. It gives him unfettered powers. Unfettered powers kind of thing that he can wake up one morning and say, you know what, it's now fully implemented. So no one knows what criteria he will use for administrative function, that is to say, it's fully implemented. So as you go along in the bill, you'll pick up a whole lot of things that raises constitutional issues. And this is an administrative issue where he's got unfettered powers at this stage.
Certainly, sure. And it
Scary
gets
stuff.
deeper and deeper.
It's
It
very
gets deeper
scary.
and
So
deeper, and very scary for the users of our health system indeed. I mean, just the when you look at the referral pathways that are being set out by the bill now, this conflicts with the Patients' Right Charter, leave alone the Constitution and everything else. But patients that are normally, as a person, you're allowed to choose the healthcare service that you choose to seek and the provider you choose to attend. But according to the NHI bill, all of that seems to be negated. And
Yes.
again, as you mentioned several times now, not carefully thought out.
Yeah.
Well, the drafting is also not well thought out. In fact, when they talk about registering as a service provider, the wording of the documents you need to take along with you. The intention is that adults would come with an ID and children will come with the full birth certificate, the unabridged birth certificate. But the way it is worded, it means anyone out there, whether you're a child or an adult, you must come with both an ID and an unabridged birth certificate. Now, that's the extent of poor drafting. And this reminds me of the scenario that we had in medical scheme environment, where there's a definition to business of medical scheme. And literally, it had to go to court for the judge to interpret two words, and or. And what it means if you got either or, if you got a and in the definition and what that actually means. And there was a judgment related to that led to the development of all this low-cost benefit options and gap products, etc., etc. So this is why it's absolutely critical that when you set up these laws, you've got to be specific about what you mean. And not just assume because you put those words that your interpretation is what will hold up. The words in law will then be judged by someone and tell you what it actually means. So you have to be so careful how you structure this thing. There's also an error in one area where it says that if you become accredited if you become accredited, you become obviously a place where people will register. But once they register with you, you can only see registered patients. Meaning you cannot see anyone who's not registered. So if you have a South African citizen who hasn't registered NHI, it means you can't see that person. If it's a foreigner that's not even entitled to NHI, because the wording is, if you're an accredited provider, you will not see anyone else. I don't think it ever was anyone's intention that be the scenario, but that's how it's worded.
Yeah, very concerning indeed. And it begs the question then, what happens to people that are unregistered, the vulnerable populations, the elderly, the asylum seekers, people that don't have access to the database to register? This shouldn't mean then that they don't have a right to access healthcare.
Absolutely.
A lot of our population don't have these identification documents.
And this is the complexity in the funding component, is that NHI will sort of take on the registered people and allocate money for that. The rest of the population, and if it takes 20 years, that means for the next 20 years, you're going to have to allocate on the basis of people registered to the NHI for money on the whatever per beneficiary allocation they create. And at the same time, you're going to have to plow money into the province to look after all those that are unregistered and those that are foreigners, etc., and those that don't meet the NHI definitions, etc. Now, the big concern I have as well in that registration document that we talked about, if you a foreign person and now a resident in this country, okay, you obviously will not have an unabridged birth certificate available in South Africa. Even if your kid was born in this country, they do not give you an unabridged birth certificate. You then have to go back to your country where you registered and you were a citizen and get an unabridged birth certificate for your kid there. And then you come back to South Africa and you do. So most of us here in this audience, we probably don't even have an unabridged birth certificate. That means we're going to have to go and stand up in long queues at Home Affairs and get that document. And this is what we are actually raising a lot in our consultation process, is these minor problems. You need to be able to fix them and make sure that those complications don't arise. Because if the Auditor General looks at these processes and finds people are registered just on ID alone, they're going to raise it as a finding, and they're going to issue our qualified audits, etc., that you're not following the law and you're not following processes as required of you.
Certainly. Thanks so much. I think it highlights a lot of unanswered questions, and only time will tell how we address these and how the general public's remarks and professional bodies' remarks on the bill, whether or not it would be taken heed to. I think on that note, I'd like to move on a little bit towards some of the governance issues and the functions of provinces, etc., around the bill. And Thelma brought up a question here as to does it mean, according to the accountability and the structures in place or being tentatively in place, does it mean we'll move to a capitation model for population health and each province will account for its own population health? And I think it begs the question now, that function of this district health management offices and the primary health care parts, and what are their roles, and what does this mean for taking away the power of provinces?
Yeah, that's another bugbear and a problem that's structured. They find these nice yuppie things out there and they think it's going to work here. So couple of important, you've actually raised about 2 or 3 questions. Let's tackle the latter one quickly, the one about the province, and then the first question we can tackle it again. That's about the capitation. And incidentally, you can blame me for the capitation being in all these documents till now, how providers should be paid. So if we look at the public sector, okay, we had a National Health Act written in 2003, or it went passed through Parliament in 2003. There's certain things that have been proclaimed, etc., put into act process. So according to the National Health Act, we're supposed to have about 50 some odd district health authorities. How many are actually effective at this point in time, and how many have been implemented? Probably nothing. So you're supposed to have about 50 of those entities. Now what they want to do is to introduce this contracting unit of primary care, a couple hundred of them. So you couldn't do 50, but now you want a couple of hundred of these contracting units of primary care. And what you're saying is that this contracting units of primary care, the function would be an entity, say it could be a sub-district or a sub-district type of thing, that this contracting unit of primary care will be responsible for. And all the GPs, the clinics and the hospitals in that area, they will put it under the umbrella and be responsible for payment to those providers. Raises an interesting question because they're talking of a single payer. But then it talks about they will pay the contracting unit of primary care, who will then pay the individual providers under their umbrella. So it's actually a multi-payer system, they're implementing a multi-payer system, and they claim to call it a single payer. So that's another bit of policy statement they're trying to put into law, which is a bit of an anomaly. And our view is, well, if you really want a multi-payer system, then allow medical schemes also in this environment to offer the same kind of benefit and exist in a multi-payer type of arrangement, as long as the medical scheme offers the same benefit you offer and whatever more that they want to. So literally and you obviously have now this district health monitoring office or whatever the case is, that will be carrying out oversight of all the contracting units under it type of thing. So you're going to have maybe a few 50, 100 type of these district health offices. Literally what it's going to be creating, as it is, we have bloated middle management structures at the provincial levels. Now you're going to add to that bloated public health, public sector structures kind of thing, overseeing the service provision. We claim we don't have money for service provision. There are budget cuts and things like that, and posts that are frozen because there isn't enough money. But now I want to create this bloated middle structure of oversight to the contracting unit. And our view is it is totally irrelevant, unnecessary kind of thing in this regard. And while they're talking of this bloated structure, there's an amendment recommended in the National Health Act. There's many functions allocated to the province, things like the health information system, the quality assurance, etc., etc. There's several of them. I think there's about 6 of them they now want to delete. What that means is that in each of the province for those functions, you're going to have redundant staff. Those functions are now going to be taken up either at the Office of Health Standard Compliance, Department of Health, or at NHI. But remember, you've got now 9 provinces having redundant staff. Not all of them are going to be employed, or they're employed by these 3 entities. You're still going to end up with redundant staff. Now, if these redundant staff can't be reallocated, there's going to be retrenchments. And I don't think anyone will want to allow that, unions will want to allow. In any case, if you are reallocating people, you literally are changing the terms of employment, and the conditions of employment will potentially change as well. And the same, obviously, with this retrenchment coming through. And really, in this kind of environment we're in, they're actually proposing these kind of strange recommendations, which will definitely lead to staff losses in terms of retrenchments out there. So that's the public sector side that's going to take place. In fact, that complementary cover, because you have negotiations that are done in central bargaining, what you're ending up with is currently a lot of subsidy going to medical schemes. If you introduce complementary cover, you are now going to have to renegotiate those subsidies, because you're going to have to determine, do those staff get the full subsidy on an ongoing basis, or do they get a reduced subsidy because complementary cover is now, the amount of benefits in the medical scheme is significantly reduced. Inevitably, what all this translates to is change in conditions of employment of people in the public sector. Just that amendment alone, complementary cover, would mean change of conditions of employment. Massive implications from an IR perspective that has not been considered in this thing.
Wow.
So
I think
it's very, very worrying.
Yeah.
And you said, this is about how it's going to affect the community. Well, this is how it's going to affect employers and people that are employed in the company. And it's equally that principle equally applicable to most of the other employers out there.
Yeah. So I think, Rajesh, on your point around implications to provinces, I think there's a constitutional requirement that provinces and provincial departments should provide emergency healthcare. If someone is injured, they're traveling wherever, they should have access to an ambulance and any facility. And it's unclear how the NHI is going to, or in an NHI environment, on how that is going to be met. Will the province get special funding for that? And then when you look at it from the patient point of view, we talked about the strategic purchasing and the contracting. So where's the ambulance going to take me? Is it a contracted facility or not? If I'm taken where it's not contracted, does it mean that the NHI fund is not going to pay that? Or that's where I was saying, I can't imagine them making a provision in law to say it shall be strategic purchasing only. Because under certain circumstances where someone goes to a provider who is not contracted, you should be able to pay fee for service. So I don't know how they drafted the act. I think there are so many things that you kind of wonder, like, but do these people really know how it actually works in practice? Have they thought through these things or not? No.
If I can add on to that, this is obviously stretching into the remuneration of providers, and it talks to the capitation. I'll touch on that in a moment. It's clear that whoever drafted this legislation or this bill don't know what a legislation is for, what the purpose of a regulation is, what purpose of policy is, and what purpose of sort of guidelines are. So there's about 5 pages in the bill about how you would pay providers, etc., and it's irrelevant. How you pay providers is about how. It's not about structuring an NHI and give it empowerment to, do the work. Most of those pages about payment is about how you do it, and therefore it belongs into regulations. So even the fact that they talk about diagnosis-related groups in legislation shows whoever was writing up this bill got no clue that diagnosis-related groups is a tool. Today, it might be fashionable to use it. Tomorrow or next year, there'll be a new tool that are out, and it might be appropriate. So because it's a tool, it should go into regulation that can be changed from time to time. You don't write those type of things in legislation. And this is why we say whoever's been sitting and drafting this, and whoever the legal person is from state law advisors, wasn't really advising the Department of Health well as to what goes in legislation and what doesn't go in legislation, what should go in regulations, what is guidelines, what is policy. Charlton talked about strategic purchasing. Strategic purchasing is a policy term. If you want to use that type of term, you need to get the lawyer to write it in legal terms, what it actually means. It actually means you get paid on the basis of the quality that you deliver. If you don't deliver quality of care, you don't necessarily get paid, or you don't get paid enough kind of thing. You get a lower payment of some sorts. And strategic purchasing is essentially saying, you deliver the outcomes I want, then you get the money. That's what strategic purchasing is. It's not about you provide a service, I pay you. It's about, I want to pay you for service that adds value, nothing more than that. That's what strategic purchasing is. And this is why, you look at that entire thing. They talk of a single funder. Single funder is a policy term once again. Shouldn't belong into law at all. And yet they make those type of errors. So coming back to that question about capitation. So the primary care service are bread and basket type of services that can be pooled in a basket, and you can pay people accordingly. But remember, the doctor on the left-hand side, for example, might see elderly patients. A doctor on the right-hand side, Taposi, may see young patients. The health needs are very different. And if the health needs are different, the cost of delivering service is different. So you can't use a simple capitation like they do currently in allocating to provinces. Right now, money is allocated to provinces on the basis of headcount. And there is some adjustments made for like the academic hospitals and things like that. And a year in there, oh, you got more HIV, let me allocate more because of your HIV. So to pay providers of service a fee that is sort of takes into account the health need, you then come up with what we call a risk-adjusted capitation. Okay. And for example, younger people will have less health needs. Older people might have a lot more health needs. Females might have a lot more health needs in the reproductive age group because of the pregnancies and deliveries that you need to then adjust for. People might have certain chronic diseases. So if you register in your system the chronic diseases, you can potentially adjust for the chronic disease people might have. And that's the kind of risk-based capitation that you put into place, is that you then give a single lump sum figure for a month based on the kind of patients that register with their practice, and they based on their healthcare needs that they have. Now, obviously, if you look at a province level as a service provider, then whoever is registered on the NHI will get capitated payments for that risk pool that is registered with the NHI through that risk-adjusted capitation. So in principle, it makes sense. But the technical details of how you do it are much more complex. And therefore, those things, you don't write it in legislation. Even the whole thing of risk-based capital, you don't write it in legislation. Legislation has to be very simple and says, the purpose of this NHI fund will be to reimburse service providers for healthcare delivered to those who are users. And we can talk about users and what the definition of user is, to people that are registered on the NHI, and the method of remunerating will be determined by the minister. So it's something as simple as that you put in legislation. When you go into regulation, that's when you can unpack it in a lot more detail, that you will pay hospitals using diagnosis-related groups. Diagnosis-related groups is mostly for inpatient. Some are sort of day cases, but there's a whole lot, about 60% of hospitalization is day case admissions. So are you saying that you're not going to use some kind of ambulatory procedure groups or so, of sorts, and you're only going to pay people on DRG? There's a 60% you're actually carving out of the whole equation. Are you not going to go into fixed fee arrangements of sorts, etc.? So you can see that, they took something that was there historically, added on, and they literally copied, pasted it, and, put a few more flowery words around it, and not really think this through, because those people who've written this legislation and this bill have really not worked in an environment where you remunerate providers. It is clear to people like myself, Charlton, who worked in this environment, of what is required when you are paying providers of service.
Sure.
I hope
Thank
I've
you so
answered
much
that
for
question
that.
about capitation and provinces.
I think you have. And Rajesh, you touched on, so there's a lot of information coming out here, and you spoke a lot about employment and the impact of the NHI on the public sector. I think it's only fair then to balance this discussion out with the impact on the private sector, including funders, medical aid schemes, what happens in the event that this NHI is implemented or enforced, what happens to the millions of employees in working for medical aid schemes. And on the same note, maybe another follow-up to that, on the broader spectrum then, if there's a single payer, single fund mechanism for healthcare along its spectrum, is litigation costs for the private sector then also going to be covered by this fund? Or does that only still apply to the public sector? And I think these are major questions that providers in the private sector have, because they are impacted equally, if not more, by these decisions being taken.
The issue of that litigation and that liability issue has not even crossed anyone's mind in writing this legislation. So it's a big question mark on that one there. You probably assume that the service provider would potentially be responsible for that. And that's why in the remuneration structures kind of thing that will be determined, you will need to take into the account the litigation. So this is why I fully understand the strategic purchasing, is that if you deliver quality of care, the likelihood is you won't be litigated against. And therefore, the quality assurance and the responsibility of service providers is to make sure all the quality assurance requirements are put into place. You know, if you're running a health business, then you need to know all the tools that are required for running a health business. And obviously the first component, and if you look at the Donabedian model of assessment, quality assessment, it starts with structure. Do you have all the right structures in place? And quality assurance helps you with a lot of that essential infrastructure that you need to have. The quality assurance will guide you. Should you be having a BP machine? You know, what kind of medicines you need to stock, the equipment you need to stock, etc., etc. Obviously, the providers need to be up to date with their CPD, up to date with their knowledge, etc. in this regard. So those are a lot of structural elements kind of thing. And if you look at a lot of the problems that you've seen in the province with litigation, they're not related to the professional services. They're often related because of lack of equipment for monitoring and things like that might have been around that led to some of the complications and problems out there. So on that answer, no, litigation is, I don't think anyone's even considered that. To me, when we talked, this is why in the remuneration side of it, to me, it has to be included, because in the private sector, when we determine provider fees, the so-called professional indemnity they pay is sort of incorporated into those consultation fees, etc. And it's taken into account that when we pay your consultation fees, we know that some of your professional fees are related to the indemnity that you buy.
Yeah. Okay. I'll touch on the effect of NHI in the private sector, I think, in the employee side. So obviously, annual contributions collected are 200 billion. And then the value chain in the private sector is quite wide. I think I'm speaking to some economists, so there's the multiplier effect. So there are employees for the schemes, the administrators, that money is then turned over to health service professionals and hospitals. Some of it is turned on to the pharma industry. So it's quite a large amount of stakeholders who actually rely on the private funding for healthcare to survive, employment-wise as well. So taking that away, obviously, is going to have a huge impact on the economy. I think it's almost ignored, the contribution of the private sector. And then I think the other element which I kind of mentioned in my discussion is the employers, they also rely on the private funding to ensure that they have a healthy workforce available. And they look at that when they are resourcing for their staff, and they want to have that assurance in place. In most instances, they really rely on the government. And then I think importantly, for the sake of health service provision, I did mention that health service providers in environments where there's NHI, they also rely on private funding to balance the books. It's not really practical for the government to believe that they'll be able to push down prices for everyone, and then things become affordable. there's always an element of cross-subsidization. If you look at HIV drugs, for instance, the private sector indirectly cross-subsidizes the government. The private sector, I think it pays 4 or 5 times more than they would for the doses. We saw the same during COVID. The private sector was paying twice as much so that the government could fund for those who did not have medical scheme cover. And then the numbers in the private sector is just not limited to your medical scheme lives, the 9 million. It also includes a certain industry which we don't like, which Rajesh was talking about, the health insurance industry, which is providing healthcare. It's also become a very important funder of healthcare. So just wishing away medical schemes and private funding for healthcare, it will have a huge impact on the economy just because of the lost opportunity and the lost jobs. And then private sector exists for a reason in its current form. I think in my introductory remarks, I mentioned the complexity of the environment. These skills and these sets of employed groups and so on, they're important for provision of healthcare. The NHI needs to almost have similar structures. One forgotten element is mitigating fraud, waste, and abuse in healthcare. It's well documented across the world that losses due to that could be as high as about 10 to 15%, depending on your controls. And it's 10 to 15% of the total healthcare expenditure. So that's a huge amount of money. And when we now look at the bill and the fact that it's the health service provider who's going to be registering patients, it's a big red flag. You don't do that because that's a conflicted person. He wants as many patients as much as possible. And if you say he's the one registering patients and then he's going to be remunerated based on the number of patients he's registering, I think you've heard of ghost employees. You're going to have many ghost patients on the NHI. You talked about the remuneration, it will be capitation. So the fact that I have got a patient, whether I service the patient or not, I'm going to get paid. So what signal are you sending to the market? People respond to the structures you have put in place so that they survive. So I think just like Rajesh was saying, the drafters have not thought through the various incentives that are available in a healthcare system and how you should manage the risks associated with that. And I think the economic impact of just wishing away the private funding for healthcare is going to be huge, to the point that it might even risk the implementation of NHI successfully.
Thank you very much for that, Charlton. I think on that note, then, the impact of this NHI on providers, so doctors, nurses, allied healthcare workers in the private sector and the public sector. Has there been any consideration of what happens to how they are remunerated? I mean, everyone's demotivated at the moment. There's talk in the media all along about immigration rates increasing to 40% amongst doctors of South Africa if the NHI is implemented. What's happening in the discussion and in terms of the bill with relation to that, if anything?
I think I'll start with it and then Charlton can come in a lot more on the human resource side of it. I think that's a little bit exaggerated in terms of people's reaction to this NHI. Because inevitably as South Africa, if we leave here, we only end up going to one of the other Commonwealth countries type of thing, Canada, Australia, New Zealand, and US type of thing. And in reality, if you look at most of those countries, they already have NHI available. Those places determine how much money you're going to earn, how you're going to be earning. They even, places like Australia already have things like certificate of needs. You can't go and set up a practice wherever you want to, etc. So literally all the things they want to fight against in South Africa, those things are almost all in place in those other countries. Even in US, you can't just go there and set up a practice wherever you like. You know, if you want to go and work in any state, you have to make sure you meet those state requirements to register. And that too, you can only go and practice in certain regions. If you're new in that area, inevitably you get thrown into the rural areas type of thing. So all the things, you know, this is why I say that's probably an overreaction from people. I would still think there's huge opportunity for delivery in South Africa for things to work out well. I don't think anyone will want to under-remunerate providers because we know they're scarce resource. So, you know, we're all trying to work towards fair and equitable remuneration for service providers that should result in a win-win. The moment a funder and a provider engage in a win-lose scenario, everyone's going to lose, because the funder is not going to be able to retain the members. Those members will go out of the system and go and get their own healthcare, etc., kind of thing. As Charlton talked about, they'll go to external funders, insurers, and buy that external insurance. So it's always good to try and work towards common solutions. And I think the private sector right now is ideal in a position to be able to test out all these different type of remuneration systems with providers. And it's just unfortunate this last decade, government has been reluctant to want to engage with the funding environment to even test these type of things. They're happy to pilot certain things in the public sector, but those remuneration models are ideal to try out in what you call it, the private sector. And in fact, if government is pushing NHI, you have a government medical scheme, you know, who would, I'm sure, be willing to try out these different type of things and to see if it works, doesn't work, etc. So I'm one of those people to say there's a lot of opportunity in South Africa. We don't need to panic and, you know, throw the toys out of the cot and say we're leaving. There's really no need for that type of thing. There's huge opportunity in South Africa, both in private sector as well as in public sector.
Lovely. Charlton, anything from you on this?
Yeah, so I think I concur with Rajesh's comments to a point, because I think we should not ignore the risk. I don't think they are running away from NHI per se or the certificate of need, but rather it goes now into the details of how it's being implemented here and how it is being implemented and run in other countries. So I think if we fail to implement it correctly, then that risk is obviously heightened. And just to also balance my statement is you'll never have all the service providers leave. You always lose some and some will always stay. So I think it's something that should be managed in a way which is not arrogant. We should still listen to some of their concerns and make sure that we have the best structure for them. And then we have a good chance of retaining a lot of their skills. So we, as the BHF, do run the PCNS, which is a system for registering service providers so that they can claim from schemes. And we obviously monitor trends in terms of their movement. We have been seeing some of the specialists before retirement deregistering from PCNS. We know that the state is not employing them. So obviously there is some evidence that there is some outward migration. But like Rajesh is saying, it's not something to panic about. Though I would still caution and say, let's have rules of the game that are fair and so on, and then we'll have enough service providers. But if we continue mixing things up, I think I talked about the 5 things that the hoops that a service provider needs to jump through. I think that will just add on to the frustrations that they are facing. If we have facilities that are not properly serviced, it will just mess up their conditions of service and make them leave. So I think, so we talked about the impact. I'm just trying to make sure that I answer your question on service providers. We talked about the contracting. We also talked about the uncertainties around how they will be remunerated. I think, yeah, so far it looks like we probably have covered most of the issues, and I think, yeah, I think it's responded balancedly. Yeah.
Perfect. Thank you so much. So it's almost like a reason for excuse, the way you put it, and calm everyone's minds about it. So we might as well immigrate you to load shedding instead. Great.
Yeah, I think factors like load shedding, the economy, etc., might be more sort of motivation to want to leave here than the healthcare environment.
Absolutely. Certainly.
Yeah.
Thank you so much for that. I want to touch on one of the comments in the chat, if we may, and slightly moving ahead with this conversation. So Sylvester touches on, Sylvester's got no hope for this NHI by his comment. And he touches on the corruption issues which need to be addressed if the NHI is going to be implemented. I think this brings to light then what do we need to talk about in terms of who has all the vested power. Why is this centralized power with the minister, number one? And they would also like Charlton or yourself, Rajesh, to touch on the Competition Act and how the NHI bill is being affected by that, and the almost rules that have been put in place when it comes to abiding by that act.
Okay, let's
Yeah,
start. Charlton, you want to go through it?
I was going to talk about the powers of the minister in his role. In this role, should I go or you?
Go for it. Go for it.
Okay.
And who
Right.
pays
So,
him?
yeah. So I think I just talked about the benefit advisory committees. So that is actually provided for in the National Health Act. I think the idea of forming committees is provided for in the National Act. We also see the same happening here. And they called it a benefits advisory committee, which sits outside the fund, and the minister is going to appoint that benefits advisory committee. Then the fund itself, it's going to have a board, which is going to be appointed by the minister, and the minister is also going to appoint the chair of the board. What we normally find is the chairman is selected by his peers to be the chair of the board. But surprisingly, the minister was going to do that. Then the fund is going to have a CEO who is also going to be appointed by the minister. So the CEO is not appointed by the board. His boss is the minister, and I'm not sure what he will be reporting to the board if he's also appointed by the minister. So clearly the functioning of the board and the office of the CEO are greatly compromised because the chairman can exercise power over the board. And I'm not sure to what extent the chairman and the board can exercise power over the CEO. They cannot fire him and so on. So governance-wise, that's a problem. And then Rajesh mentioned how the board is told what to do by a benefits advisory committee who do not have sight of the financials of maybe they will, but they are not held responsible for the functions of the fund, but still they will determine what you're supposed to pay. So there's a real risk that there will be a huge unfunded liability. Then the bigger problem is when the fund does things, it has to do it in consultation with the minister, right? So the minister has become very operational. It's not just the board which is operational, which is a problem, but the executive head who is, I don't know, it almost sounds like the board is useless. And then the CEO, before he makes certain decisions, contracting with service providers, purchasing staff, he has to go and consult the minister. So the minister is really central in terms of the governance of the NHI fund. And then I think there's talk about purchaser provider split. The minister is still responsible for running the facilities and health service provision. So if we have a rogue minister, then the fund is going to fail, right? Just that. And then we have a board which is disempowered. I think in our submission, we're almost saying, why are you going to have a board at all if the board cannot do what a board does? It almost seems like if things go wrong, the minister is going to blame the board, yet he was telling the board what to do and stuff like that. So governance-wise, that's the problem. And then there's almost this idea of trying to insulate the fund from performance. I'll touch on two things just to say that the idea of taking away schemes and saying, we don't want you to offer the same benefit. It's almost like to say, I want to be the one who's going to provide this benefit exclusively, no one else. And then when you take away competition like that, you almost have no incentive to do well. So they're trying to say, we want you to belong to the NHI fund for, let's say, if they say renal dialysis is provided by the fund, then it shall not be funded by anyone else, and everyone is just stuck there, right? And the rationale they sell to us when they are present about this is so that we can negotiate collectively, which is absolute rubbish. You can negotiate on behalf of the whole industry, and then everyone pays the same price, and they have many pots of funding. Then the second thing is exemption from Competition Act. So they almost want to have monopoly, right? So that they can determine prices. I think if I was a pharmaceutical, I would really be worried about that. They want to exclusively be the ones who buy certain products, and schemes are not supposed to do it, and then they want to have control over that. So it doesn't look to me like when you read the bill, they are confident that it's going to offer the best quality service and so on, because of all these things that are meant to insulate it from performance. I think to contrast, Zambia recently introduced an NHI fund, and the way they introduced it was they just introduced a payroll tax, 1% from the employer, 1% from the employees. And then they told people where to access care, and they still left people to join medical schemes if they wanted, and so on. They didn't talk about what happens. So people still had a choice. And what they were saying a few years back was people were now asking, why do I still have to pay for my medical aid when I'm getting exactly the same type of benefit from the NHI fund? So I think an environment where the fund opens itself up to compete so that it offers the best quality is better than where they try to legislate competition out and be the sole ones doing certain things. Rajesh?
Yeah, I think the important thing in that competition issue is the role of the provider in decision-making about the level of remuneration. You know, like Charlton said earlier, contracting is a two-way street between two parties. And the way I get the sense from just the talk out there is that the fund will determine how much you get paid, and that's how it's going to go. And in reality, when it comes to professional people, that's not how you respect them and treat them. And because they are important stakeholder thing. So usually what you need to do, and what's missing in this whole legislation, you know, there's the three, as I said, talked about, there's like 4 or 5 pages of how you would determine prices, how you would remunerate, but nowhere is there anything about the stakeholders will be consulted. And really, you know, that's an important thing, is that you need to create a framework for negotiation. South Africa's got nothing like that anyway. So even that within the NHI environment is missing, that you create a kind of a body or even a committee or whatever, or platform where providers and funders will sit, as in funder as in NHI, will sit and discuss the needs, etc., and come to some kind of consultative process and a determination of fair remuneration. None of that exists. The way it's written out now, it will be a top-down thing. And I don't think that's the way to go. In fact, if you look at even the Charlton was the governance issue, the appointment of the board, it's like there'll be nominations coming through, the Department of Health will filter it, and it will be a sample will be taken to the cabinet, and that's the improvement bit, and cabinet will then appoint the board. But nowhere in this thing is there anything about consulting the public to determine who's appropriate for the board, etc. You know, they, as Department of Health, will set criteria type of thing, but that criteria is not even published. In a bill such as this, you would want to list the criteria for people to qualify for a board, at least in the legislation where you're saying fit and proper as an example of what is needed, and a few other qualifications. You know, it's absolutely critical to list that. Compared to the way they put it, it's just not on.
Certainly.
You know,
I
the
think that
competition thing obviously may not, you know, you really don't want providers to compete on price. Literally, because in the healthcare environment, the competition is not about a commodity where you compete and the price drops. In reality, healthcare, the competition is about who can get the maximum out of the system from a tolerability perspective type of thing. So it's more about how high can I push the price up. So we don't talk about competition or competition related pricing where it's a social benefit. Competition pricing makes sense for commodities where you have a discretion whether to buy it or not buy it. Healthcare, you have no discretion about buying it. It's a need. And in South Africa, because of Section 27, and let's not forget, there's a thing called Section 28 for children as well. Okay? It's a constitutional mandate and access to care. Therefore, we have to treat healthcare access as literally a social benefit. And you have to deal with it as such. So competition really shouldn't apply in this environment, but there's a need for a lot of consultation with all stakeholders to make this work.
I think that, yeah, that clarifies a lot there. And one of the concerns and a lot of public voice that lends to this issue of competition and these anti-competitive measures per se is that does this NHI and the amount of power vested with the minister lend itself to potentially glamorized tender processes, number one? And then the second thing is when there's grievances and complaints, is the minister still then the person that's answerable and accountable for this?
If I recall reading it correctly, the minister is the one that appoints the people on that review panel on the appeal committee. So, it's a gemors. I think the Afrikaans word is really what I like. It's a royal gemors there, what you have here. Really, really poorly thought through. I want to actually talk about, there's another act that was our bill that was created by Treasury called Conduct of Financial Institution Bill. You should take that out and put this one next to it and read it. And you can see the one looks like it's real quality work. And people had thought things through. The legal advice they got was good. And this one here, which is like a mediocre document, sitting next to that Kofi bill. And it really speaks volumes of the type of people who are involved in writing this bill. And unfortunately that we have to come to those type of conclusion. It's really not, you don't feel confident about the leadership that's sitting in Department of Health and the minister, whoever was writing up this bill.
Yeah. So I think
you asked the question earlier about corruption and trust, etc. We're in an environment where there's so much of corruption, and really, as much as there's talk about addressing corruption, there's no action or very little action. So until government overcomes that corruption issue and really builds trust kind of thing, or earns people's trust in them, people are going to be very, very suspicious of this NHI in the format it is right now. In fact, BHF MD has actually been on record to say, we fully support NHI, but the content of this bill, in the format in which it is, we don't believe it's fit for purpose. We don't believe it will contribute towards moving towards universal healthcare coverage. If anything at all, it might take us backwards kind of thing, and that's how bad this bill actually is. There was a question in the Q&A about KPIs and measuring performance, etc. I wonder if I can throw my partner under the bus here and ask him if he can maybe take out his effective coverage report on the portal to show people that if you've got data and that you can develop metrics and measure performance in this regard. Charlton, can I ask you to maybe share that effective coverage report on your portal, just at a high level, and show that component? It might take about 5-10 minutes, Navisha, if we can at the end.
That would be perfect. Thank you. I think so while Charlton's looking at that, the comments coming through are quite dismal. I mean, Rochelle saying the NHI should have concerned itself with basic healthcare support for all citizens, and certain hospitals and top of cover for citizens who want other facility care. People should have a choice in their healthcare decisions, which we all fully agree with, and that comes to whether or not this constitution is, protected when it comes to this. And then in the Q&A as well, someone fully supports the NHI but worried about funding proposals. SA already has one of the highest PAYE tax rates in the world, second
Very
highest
true.
in Africa. What's going to happen now? Where will funds come from other than taxpayers' pockets? And
Just on
any
that one,
further
if you're
tax
going to
increase
tax
will suffer.
people, if you're going to tax people already that are at a high level, those are the kind of things that will chase the service providers out of the country.
Yeah.
Yeah, so I think once again, I think those comments go back to what I had said earlier around what is NHI, because NHI is simply a funding vehicle. The bill should be very short, it should be very precise. We are going to collect tax money and we are going to pay for people's healthcare needs. And this will be defined through regulations, and we're going to use appropriate methods of reinvestment, and then a governance structure. And it should be that simple. And then the issues that people complain about when they discuss NHI, they're actually health service provision issues, which should be addressed anyway, whether there's an NHI or not. But it's just that, unfortunately, things have become so convoluted. And when we are talking about funding for health, we end up talking about health service provision because that's what they put in the bill. It's a bit unfortunate. I've seen legislations where you set up funds. They are very simple legislations. They are not complex and they are very precise, not what we currently are sitting with. Rajesh, I am ready. Can I share my screen?
Yes, please.
Do you want me to talk to the two or you talk to the two, Rajesh?
I think what I'll do is at a high level, we develop this effective coverage as a measuring tool to monitor progress towards universal healthcare coverage. And Charlton uses a nice term. It says it gives you a measure of the extent to which you're meeting healthcare needs. So both terms sort of identify the same thing. And obviously, if you've got data, you can measure it, and there are metrics kind of thing that we put in place, etc. And effectively, what you are measuring here is identifying the at-risk population. You then measure the essential intervention that are necessary to avoid complications and adverse outcomes. That is access kind of thing for that at-risk population. And finally, you measure the adverse outcomes, and more particularly, the inverse of the adverse outcomes, that is the number of people who remain adverse outcome free. And you take these three components and you work out the score. And that score gives you a sense of all your at-risk people, they've received the intervention that is desirable and remains healthy type of thing. And obviously, at the end of the day, you want to make sure all your at-risk people get the interventions they want and adverse outcome free all the time. So the higher the score, obviously, the better, the healthier the population, etc. And what we've done is to then adapt this effective coverage for the Southern African region. And we literally, obviously, you get an overall score, and we covered the four main areas, which is maternity, child health, infection, non-communicable disease. But we've separated cancer, which is non-communicable disease, separately because there's an emotive component to it. And also the way we measure the at-risk population, we've separated it out. So maybe I'll let Charlton take over now just to give you a sense of how this thing works. And obviously you've got some weightings and you've got some scoring that gets done and calculating. So as you can see, these are metrics that talk about that KPIs.
Yeah, so thanks so much for that introduction, Rajesh. And I'll talk to the weightings. So these weightings are customizable to the health needs of the population. So we are working with schemes, and we are doing this effective coverage for schemes. You would find some schemes are relatively young, with an average age of 20, 25. So in young schemes, then maternal health and child health become very important. And then your NCDs and your cancers are less important. So how you actually come up with the weights, you can use, you can look at a measure to inform you of the health needs. You can use mortality. What are people dying from? You can use hospital admissions. So you can just come up with an objective way of determining the health needs of your population. In terms of infection, if you have a young scheme in a mining environment, I think respiratory diseases become very important. and HIV become important, and then you adjust the weights. So at the end of the day, the weights will then give you a matrix on which to measure how well you are performing in terms of looking after the health needs of your population, because the weights speak to the health needs. I think I will show you how it actually works for one condition. If we look at diabetes, we use the age profile or the risk profile of the scheme to estimate.
Dalton, you've used hypertension.
You want hypertension?
Yeah, I think you selected hypertension.
Oh, I use that. Okay, I use hypertension. Okay, I can talk to hypertension. That's fine. So we look at your age profile as well as your gender and estimate what your potential disease burden for hypertension would be. For this test scheme, it is almost 200 per 1,000 lives. Then we compare that with how many lives you have in your risk register. And in this case, it was 122. So your score at the health need level that Rajesh talked about, it drops down to 62%, because we are saying that you have some hypertensives that you have not yet identified. And the messaging here is, as a scheme, you should put in place measures to go and screen more people so that you know of them. And then obviously the way we designed the tool is for you to compare yourself against the industry. And then the next thing, we now say for those lives identified, how many are receiving the right interventions to manage hypertension? So we have minimum criteria for stable patients that should be provided. And in this case, they should take their hypertension medicine, and then they should have their kidney function tested at least once a year, and then cholesterol testing. And then the weights for these interventions are medicine compliance is 60%, and then kidney function testing 20%, cholesterol testing is 20%. And by medicine compliance, here we use a proxy indicator of actual claims coming through the scheme. So if someone takes the medication and doesn't actually swallow the pill, we will not know about it, but at least if they are claiming for their meds, we use that, and we use a threshold of 80% for the year. So if they've claimed 80% in a 12-month period, then we say they are compliant. And then this figure of 34%, I think it matches an article which I saw recently to say that only 40% of the people are taking their cardiovascular medication consistently. And when one looks at the score at the interventions level, you weight the actual proportion meeting that criteria to the weight, and in this case it's 37%. And when one looks at this, if they want to improve their score or the care provided to the patients, they need to encourage them to take more of their meds and then go for cholesterol testing. Then they will bump up their score. Then the last leg is looking at all these patients who have received the necessary interventions, how many remain adverse outcome free. So we call it intervention success. And the outcomes we look at is all-cause mortality, and then the actual blood pressure level and number of stroke admissions. And because these guys are compliant and they are being monitored, you'll find that these scores tend to be very high, which is what you would expect anyway. And then the overall score for the specific condition becomes a multiple of the success intervention, interventions provided, as well as the health need identified. And then it comes up to a score of 23%. So we are using this to improve the level of accountability in medical schemes so that they just don't focus on the money management, but also focus on the health management. They respond to the health needs. And then when it comes to apportioning resources, they know where to go. If you look at the overall summary, you can see the scores for everything broadly, and then you can go into detail. So for this scheme, I would say, okay, we need to do a lot more in terms of infection control. That's where the lowest score is. And we have to focus on tuberculosis and pneumonia. And then if you want to improve your score for NCDs, hypertension is where you need to pay more attention. And then if you go into the specific condition, you'll be able to tell where exactly your gaps are. So this is just one tool to improve the accountability from a health perspective. I think for every condition, there's a lot more detail as you go through it in terms of what actually is going on.
And this type of tool, you can even use it at the facility level. You know, we've identified a whole lot of what you call it, non-parametric measures, or Charlton is non-parametric measures that you can use to be able to slice and dice this kind of information. So you can even take this data of a facility and be able to report it in this way and start scoring them. And this kind of thing provides a nice way to do the KPIs that you were referring to.
Well, I think that's a fantastic tool for monitoring, and I can see there's a lot of work gone into it. And back to the topic of NHI, I'm going to touch on that tool. Now, in order for NHI to happen, we need a national health information system. And part of the requirement for measuring and for KPIs of this nature is that we need information and we need data. Now, in most of the public sector, we're stuck with no internet, no electricity, no telephones, no power sources. We actually in a hole, to say it bluntly. Like, how will we get to that point of achieving such metrics? I mean, what else is going to inform primary healthcare strengthening the provisions at primary healthcare level if we don't have metrics like that in place?
Well, the NHI bill actually says that NHI will sort that out because they're taking that power away from the province and creating it centrally. So by magic, someone will out there centrally will put it into place. I mean, there's a thing called NISA who's supposed to do this type of thing, and that's supposed to have been in existence since like 2003 or something. And over the last 2 decades, nothing has happened. So I'm not sure when we'll ever get to see that type of thing. I recall in the 2000s, I had discussions with Shane Cote, who was the head of the IT and systems and things like that at Department of Health. And we talked about the health information system kind of thing, a national one. And at that stage, the population, I think, was still about 45, 50 million. And we said for a population of 45, 50 million, we need one database. And yes, people can interface in that database type of thing. So whether it's a medical scheme that interfaces, or GP practice interfaces, or the public sector interfaces kind of thing, even if different provinces choose different type of health information systems, you can interface into that. And unfortunately, we've gone through almost 2 decades, or just under 2 decades since that discussion, and we're nowhere close to any kind of health information system. But it seems like that Department of Health definitely wants to develop something. Whether it's the NHI that will develop it or not, I'm not too sure, but I got a sense that that's one of the parameters, and I know they're setting up a IT department to be able to do a whole lot of that component. The original work and that registration stuff that they were doing in public sector was supposed to be part of that health information system. But I think that process was just a collection of patients that were registering. And if you really go and interrogate the database in that collection, there'll be multiple of duplicates and triplicates and quadruplicates, depending on the patient visiting that facility and depending on which facility they attended to. I remember in that system, there was no checks and balances kind of thing for, if a person was there before, then it would show up that you don't need to capture this again. There was no validity, if I recall, in that system originally.
Thank you, Rajesh.
If I can just respond to the comment there around engagement, I think the biggest tragedy of the whole NHI process has been the lack of engagement. And it's universal. It's not just service providers. This bill was put up somewhere. A lot of detail was worked on it, and it has been just brought down to us. Even the parliamentary process itself, it wasn't, I'm looking for a nice word, it wasn't productive. When the BHF made its submission, it was clear that the parliamentarians had not got the bill. No one even questioned us on the content of our submission or tried to understand why we were saying certain things. We watched other submissions at Parliament. the same was happening. There was always this old question that, do you support NHI or not? Yet it's not even supposed to be supporting NHI or not. And then if you follow the public discourse at the moment, most of it is actually hinged around where is the money coming from, if it's the private sector, and if it's the government, it's about how bad medical schemes are and how NHI is going to solve all the problems. So that the real unfortunate thing is there's no one who's talking to the detail in the bill, which is going to affect how NHI is rolled out. And I think it's a lost opportunity because the NHI fund is for everyone. Everyone will be affected by the healthcare system. Everyone will become a user. And it should be everyone's business understanding the bill and what's going on. When you listen to some of the officials, I was just sharing today, it's very partnerizing. I don't know. They ask the audience if you have read the bill from page to page, if you read certain clauses, yet when you make law, you don't expect your population to read the bill. It's a wrong expectation because we are not lawyers and very few people would understand the legal terms that are in the bill. What must happen is the bill must be explained to people so that they can interact with it and give valuable input. But they are almost saying, because you have not read the bill, you should not talk about the intricacies of the bill because you don't know about it, which is quite unfortunate in terms of what democracy is and what stakeholder engagement should be about when you make laws. So I think that's my perspective around the engagement, and it's universal. No one has been engaged. And when you have these engagements with people who come up and stand in supporting the bill, the moment they start knowing some of the details, they'll say, oh, I do like NHI, but I'm very uncomfortable with this detail. This was not debated. This was not discussed. Yet all these engagements, they really should be about the content of the bill rather than what people are talking about.
Thank you, Charlton. I think it's been a very fruitful discussion thus far indeed. And before I sum up, there's just one more question that's outstanding. We didn't quite address, but we did in many ways. So Dr. Hargovan asks, who decides on the role of private healthcare providers and private hospitals, as there seems to be a lack of cooperation by government to negotiate? And I think that's it. I think everyone is subject to the same principles under the NHI, whether you're private or public, and you have to undergo the same accreditation processes, etc., and have another visit by the Office of Healthcare Standards and Compliance.
I think, from that perspective, it's absolutely right what Charlton said. There hasn't been sufficient consultation. Although after this bill was published, kind of thing, they are engaging. I know at the GP level, they're engaging with the IPAs and SAMA to work with the Office of Health Standard Compliance kind of thing on the accreditation criteria that will be applied to the GPs. But I'm not sure, if we look at, Charlton was talking of the practice code numbering that we administer. There's about 70,000 practice numbers issued out there. How is the Office of Standard Compliance with its limited resources, going to accredit all of these private sector ones? Forget about the public sector ones getting full accreditation because of the problems they've been inspected once already. How are they going to go through 70,000 providers out there and try to work through the accreditation? And this is 70,000 of all type of disciplines and facilities. Do they have the criteria for all these type of services out there?
Indeed. Thank you very much, Rajesh. Well, if there's no other questions or comments at this point, I would like to say thank you all so much both for the fantastic insights tonight. The metrics that you showed us, I think that's a remarkable achievement, and hopefully it can continue and spread across the sectors in future. So to summarize everything we've touched on this evening, it sounds like what needs to happen. And I'm no minister or anyone else with any power, but it sounds like the health system is in need of complete infrastructural overhaul, number one. We don't have the right systems in place. Number two, we need decentralization of the powers that be when it comes to handling of the fund and administration of the bill. And number 3, we probably need to relook how relook at alternatives to the NHI fund entirely. And there's been talk about it and discussion and debate about it already, things like the low cost benefit option, which will actually remove the burden on the public healthcare system somewhat by enabling people to access private healthcare, which might solve a lot of the problem we currently have in terms of care delivery and service delivery. But also things like the NHI as a fund, it's a good mechanism, but maybe it shouldn't be structured in the way it is, but maybe it's more suited to public-private partnerships, for example, rather than a sole entity that is required to provide healthcare for everyone. So yeah, that's how I would sum up the session. Still a lot of unanswered questions, but I think everybody is on the same page in terms of where we are. So my closing questions to Rajesh and Charlton both. So NHI implementation scheduled for 2026. Public comment closing on the 17th of September 2023. What is your gut feeling in terms of a way forward? Is this going to happen or is it not? In the time frame stipulated.
Charlton, if I can start, there's election next year and all this push is for that purpose. That's what I believe, or that's what I think the main reason for this whole thing being fast-tracked in the way it is. It's more for election and trying to tell the public out there, see, we delivered something for you. The fact that what you'd be delivering here is not of good quality says a lot, because if this is what you do to law, what are you going to do about people's health? Are you going to put that kind of quality emphasis type of thing on the people's health as well? And this is what worries me the most, is that, you know, if this is what they think about doing their work, how they believe they should be doing their work, do they really care about you and what you need for your health and the quality that you need for your health, if they're not even bothered about what they do in their daily lives? It's very worrying.
That's indeed. And everything will probably go quiet again after election season.
Yeah.
Well, we hope that there's still a process to go through and that the president decides to throw away all his pens.
Yeah. I think it's an election too, like Rajesh says. And if I would bet my money on how it's going to pan out, it's going to be signed. It's going to sail through the provinces with all its brokenness. Maybe the president might even sign it. And then it's going to sit in court. And then we would have lost time.
Thank you very much, both.
Yeah.
Everyone's very appreciative of the discussions tonight. I think we're just over our time. Rajesh and Charlton, our sincere thanks for spending time this evening to enlighten us more about this bill and fund and providing your expert insights into the bill. We know you're heavily involved in the discussions and dialogue and debate that's out there. And we sincerely appreciate all of your efforts in trying to move healthcare forward. So thank you both again so much for this evening. We sincerely appreciate it. And we hope to invite you back soon for the next session.
Thank you very much. It was great being here and it was nice engaging with everybody. Thanks a lot.
Thank you so much. Thank you, everyone, and have a lovely evening. Take care.
Bye.
Bye.
Bye. Thanks so much. Bye.